Good morning, everybody, and welcome to the second webinar in the Lethe project webinar series. It's a pleasure to have you here with us today. And today we're going to be focusing on the multi-domain intervention trials in the prevention of cognitive decline. It's a pleasure to be your moderator this morning. My name is John Switters. I am a senior research associate and project coordinator at the Lisbon Council, which is a think tank and policy network based in Brussels in Belgium. And we are a project partner in the Lethe project. So it's great to be here with you today. And I'm very well accompanied. So just some housekeeping rules just before we get started. This webinar is being recorded, so please be aware of that. And it will be posted shortly after the event on the project website. The audio and video settings, please turn off your camera and mute your microphones. That just helps us have a clear audio. And then if you have any questions and comments, then please use the chat function and we'll address these during the question and answer session, which will come towards the end of the webinar itself. So we'll try and get through as many questions as we have. Please be active and ask our panelists any questions that you may have or any doubts or comments to their presentations, that they are all well received. And finally, captions are available, automated captions. So please click on more on your meeting options, and then you'll find the option to turn on the automated captions there. So the agenda for today. We will start with the welcome and introduction. We'll then have a look at an introduction to multi-domain intervention trials. Oh, sorry, a little bit of noise there. We will then look at the Lethe randomized control feasibility trial, and finally have a look at the Lethe sub-studies, taking into account the Temi robot and the Fauna audio glasses. The idea is then to have a short panel discussion with our speakers, and then open the questions. So all the questions that you may have put in the chat during the webinar, we will then address those to our speakers. Today, as I said, I'm very well accompanied. We have Francesca Mangialeche, who is a geriatrician, an executive director of Worldwide Fingers. We also have Elizabeth Stogman, who's associate professor at the Department of Neurology at the Medical University of Vienna. We have Elenia Muraseco, who's a psychologist at the Division of Clinical Geriatrics at the University of Perugia. And then last but not least, we have Anna Giulia Guazzarani, who's also a psychologist at the Division of Clinical Geriatrics at the University of Perugia. So welcome to you all, and they will all have a chance to speak later on in the webinar. So before we get started, I just wanted to refresh your memory as to why we're here. So this is a webinar within the context of the Lethe project. It's one of the last standing, I think, Horizon 2020 projects. It has a budget of over 6 million euros, and it has a duration of 48 months. We actually had a short extension, which is why we're carrying on into next year. But we actually involved in the project are 15 partners from 9 different countries. And Lethe is developing a data-driven risk factor prediction model for older individuals at risk of cognitive decline. It's also developing novel digital biomarkers and a digital-enabled intervention based on the evolution of the finger study. And the objective of today's webinar is to really have a look at one of the most important parts of the Lethe project, which are the clinical trials that we are carrying out. So without further ado, I'm going to hand over to Francesca for her presentation. Please take it away, Francesca.
Can you see the slide screen?
Yes, we can.
All right. Good morning, everybody. It's a real pleasure to be with you. And as John explained, in the context of Lethe, this webinar this morning focuses on the feasibility trial. That is one of the key features of this project. And this feasibility trial comes within a larger framework of effort on risk reduction and precision prevention of dementia via multi-domain intervention. And in this brief presentation, I would like to provide an overview of this approach. The risk reduction of dementia comes from evidence from different scientific studies that shows that across the life course of a person, multiple factors can affect the risk of late life cognitive impairment and dementia. The figure that you see here is the Lancet Commission on Dementia Prevention and Care 2024. This commission has identified 14 factors that overall are estimated to contribute to 45% of dementia cases worldwide. So in theory, by managing this modifiable factor, we could prevent or at least delay a significant amount of dementia cases. And it's also important to know that the Lancet Commission 2024, it's on its third edition. And across the previous edition, there is a growth of this list, indicating that there is an increasing room for risk reduction and prevention opportunity. The WHO also produced a synthesis on the evidence for modifiable factor that can be managed to reduce the risk and prevent dementia in late life. Their guidelines for dementia risk reduction were first produced in 2019, and now they are being updated. As you can see, the list features some elements that are similar to the Lancet, while some others are different. For instance, diet is one of the pillars considered by the WHO risk reduction guidelines. The differences are mostly the consequence of the methodology used for the synthesis of the evidence, but nevertheless, the main message is there is something that can be done to reduce the risk of cognitive impairment on dementia in late life. And there are lots of studies that are being done to identify new factors, in part linked to the pandemic, like the infection per se, or impact on the mental well-being of people, giving a positive outlook on the fact that there is a lot that can be done to promote brain health in old age. Two key concepts that we need to keep in mind based on this evidence is that the multi-domain approach, meaning the simultaneous control and management of multiple risk factors, is probably needed to impact in a good and significant way brain health in old age, because the majority of the individuals is exposed during the life course, not to just one, but to multiple risk factors. So we need to manage more than one. And that could be done by lifestyle, by medication, or the combination, keeping in mind that there is no one-size-fits-all solution. So we need to have tailored approach. And this is the concept of precision medicine that is already a reality in some diseases, for instance, oncology, but is yet an emerging field in Alzheimer's disease. And it's also important to keep in mind that pure Alzheimer's disease occur in the minority of people. The majority of old people, and especially those age 75 plus, who are more likely to develop dementia, are also more likely to have mixed pathology. So different type of brain damage of vascular or neurodegenerative type that contribute to onset and progression of cognitive symptoms. And that justifies even more the multi-domain approach. When we speak of multi-domain approach, the FINGER trial has been one of the first proof of concept clinical trial testing this concept. In the FINGER, which stands for Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability, we recruited 1,260 people aged from 60 to 77 living in the community. They were identified by not having substantial cognitive problems and having dementia risk. We use a validated risk score, the CAIDE dementia risk score, which helps to identify people that have modifiable risk factors that are not well controlled. The study participants were randomized either to a control group receiving standard healthcare or a multi-domain intervention in which we simultaneously provided nutritional guidance, physical activity via attendance to the gym, cognitive training via computer program, strict monitoring of the vascular and
No. Okay. Francesca, excuse
Francesca,
your microphone.
Sorry, Francesca, if you could unmute yourself, sorry.
All right. Is now okay? Can you hear me?
Thank you. Yeah.
Okay. Where did I stop?
Just about 10 seconds ago. Apologies for that.
Okay, no, sorry. So in the finger trial, we had both group-based and individual-based session. And the individual-based were used to help people to tailor the intervention. The group-based session was enabling the social activity. The intervention lasted 2 years, but extended follow-up at 5, 7, and 11 years has been completed. And there are two main goals of this: to understand if people in the long term keep up with the healthy behavior that they have been coached, and what are the long-term consequences. Now, the first good results of the 2-year intervention was that there were no severe adverse events, and the dropout rate was 14%. This means that in this age group, it's feasible to promote healthier lifestyle, and they can keep up with it, at least in the medium short term of 2 years. By looking at the results of the trial, we could see that the intervention was associated to several benefits. Benefit on cognition, we measure improvement in global cognition and specific cognitive domains that are important to maintain independence in daily life. But there were also other beneficial effects, like low risk to cardiovascular disease, low risk to physical decline, lower risk to develop new chronic disease and being hospitalized, and people experience a better self-perceived quality of life. An intervention proved to be cost-effective and be associated to reduce access and need to the healthcare system, especially in men. So this type of approach seems to be more widely useful in older population and to be cost-effective. But as I mentioned, finger was done in Finland. So is this feasible and effective in the other population and setting? To answer this question, we founded in 2017 the Worldwide Finger Global Network of multi-domain trials for dementia risk reduction. The country that you see color in the map are all of the countries participating in the network. In dark blue are countries with ongoing trial that are like finger, although there are local adaptations to make it sustainable and feasible in other settings. In light blue, there are countries that are in the process of organizing the trial. As you can see, we're almost reaching 70 countries, and we have at least 30 trials, of which 15 have been completed. One important aspect of this network is that the data collection is done in an harmonized way. So we can join the data and do joint data analysis. And this is important because every single trial does not have the capacity to answer specific research questions that we might have. For instance, does the intervention needs to be different for female or male, for people with or without a genetic risk? So doing larger trial and pulling them together is essential to develop what we call precision prevention for Alzheimer's disease. The network is very dynamic and there is a constant sharing of information. And within the network, we have what we call the Finger 2.0 trial, meaning that it's not just adapting and testing feasibility and efficacy of the existing model, but evolving the model by, for instance, offering and adapting to people with already symptomatic cognitive problem, by adding medication, by adding digital solutions such as Lethe, and by testing implementation project. And I think this is my final slide. We are operating in a context, globally speaking, where the attitude towards dementia risk reduction and prevention are still suboptimal, and we need to keep that in mind to address them. The Alzheimer's Disease International completed this year a report asking to people in most countries a few questions. And the main results were 80% of the citizens that responded think that dementia it's a normal part of aging. And unfortunately, also the majority of the health professional interviewed think along the same line. Over a quarter of people interviewed thought that there is nothing we can do to prevent dementia, although 58% thinks that dementia is caused by lifestyle. So this means that we still need to be working to correct the conception that dementia should be accepted as a normal consequence of aging, so we can open the way to have a discussion about risk reduction and prevention. Thank you for your attention.
Francesca, thank you very much for your presentation. And we will definitely be coming back to you a little bit later on with some questions, but thank you very much. So without further ado, I would now like to introduce Elizabeth Stogman, who will be giving us a presentation about the Lethe randomized controlled feasibility trial.
Hi, good morning, everyone. I'm happy to present now the Lethe randomized controlled feasibility trial. Next slide, please, John. So the latest study, what is it? It is a pilot study to test a digitally supported multimodal lifestyle program to promote brain health in older adults. And as already mentioned by Francesca, it's strongly based on the finger protocol. We had 4 study sites involved in Vienna, Austria, Stockholm, Sweden, Perugia, Italy, and Helsinki, Finland. All participants gave an informed consent, and the study was approved by the local ethical committees. Next slide, please. Our study goal was to include 160 participants in the whole study, so 40 each study site. The most important eligibility criteria were the age of 60 to 77 years, and we wanted to include participants with a cognitive performance at a mean level or slightly lower than expected for age, but not a diagnosis of dementia. We also used the CAIDE score, which is a risk score for dementia development, which includes modifiable and non-modifiable risk factors, and is a sign for an increased risk of dementia. So higher scores indicate an increased risk of dementia, and it was supposed to be higher or equal to 6. You can see it on the right side. It comprises age, education, sex, blood pressure, body mass index, cholesterol, and physical activity. And we also try to include participants who are already digitally fit. So therefore, we included participants who already had a smartphone or were accessing the internet quite often. Next slide, please. The intervention duration was 24 months. We had a screening phase. After that, we randomized, non-stratified to an intervention group and to a control group. And we had 4 study sites at baseline and at 6, 12, and 24 months. We additionally collected data through the Lethe app, actively through questionnaires, but also passively through the monitoring of Lethe app functions. And the 2 groups were an intervention group. This group received a digital and an in-person intervention, whereas the control group only received static information about lifestyle. Next slide. This was the technical equipment. I think in the last webinar, maybe there was already more information about this, but the intervention group had the Lethe app on the smartphone or also accessible on a tablet, which was provided for the participant if necessary, and could access all the functionalities of the Lethe app. You can see it on the left side. And they also received a Fitbit smartwatch. And the control group on the other side, they only received came with only limited functionalities. They couldn't make use of every function we included in this. Next slide, please. So this is the intervention program in person for the intervention group. So there was some dietary counseling session in individual and group settings. We also did a cardiovascular risk factor counseling. We made some group sessions about for the introduction to a cognitive training web program called C-Train. C-Train is a digitally cognitive training which has a subtest for working memory, for episodic memory, for mental speed with different games in it. We also had some group activities for study participants, and there was a weekly strength training guided by a skilled physiotherapist. Next slide. And in addition, we also provided digital interventions via the Lethe app. There were videos accessible for strength training at home. A diary was provided where the participants can record number of cigarettes, blood pressure, and alcohol consumption. They could access the C-Train, as I already explained. Weekly food questionnaires were provided, and they all, or most of them, joined a WhatsApp group where they also could interact socially. We also provided some videos with soothing melodies and breathing exercises. And we had multi-domain activities as it is with personal goals and tiny habits. Next slide. I would like to focus on this a little bit more because that's a nice part in the project, I think. So the aim of this was to engage participants in changes in everyday life, which should facilitate long-term lifestyle improvement. Every one of us knows how hard this is to make changes in everyday life. And we had on one side the personal goals. We could really tailor these personal goals to the content and to the lives of the participants. We could address risk factors. For example, if someone told us that he or she liked to cycle some years ago, but now she can't do it anymore, or she can't manage to plan it, then we would have put in a sentence like, I will go cycling twice a week again. And this would appear every week to remind her, to encourage her to do it. And on the other side, we had a library of tiny habits. We could make use of this from a former study, also from the finger group, and participants could select a few. For example, I will go for a walk before breakfast, or when I chop vegetables, I chop a big amount at a time and put them in the refrigerator. And you could also choose that individual, so the ones which seemed appealing to the participants, then they could choose that ones. Next one, please. So what are our outcomes? We have as primary outcomes the feasibility. So on one hand side, the retention rate, how many participants can complete the trial, and on the other side, the adherence. So how the attendance of the participants to the intervention sessions, but also with the Lethe app. And another primary outcome is the change in dementia risk. We already mentioned the KIDE score, and another score is the LIBRA score, which mainly comprises modifiable risk factors. And we have a lot of secondary outcomes like questionnaires and tests about cognition, stress-related symptoms, healthy lifestyle, health literacy, quality of life. And additionally, we do also AD-related blood biomarkers like p-tau181 or neurofilament light chain. And we also do some brain imaging markers as we also perform MRI twice during the study. Next slide. This is the study progress. So we started the recruitment in September 22. We did the recruitment mostly through posters and social media advertisement, which worked out quite well. And we did a remote screening visit on the phone, mainly in regard of age, but also in regard of the KIDE score. And finally, we could randomize 156 participants to the study. And at the moment, we have already completed the 12-month study visit, so only the 24-month study visit is open. at that time point. Next slide, please. Here you can see the baseline data. So first results, which we already have published in the last months in the Alzheimer Research and Therapy Journal. The age is about 70 years in both groups, and we can see a quite high proportion of females and of highly educated participants. As you can see in the mini-mental state examination, a score of 28 out of 30 indicates a quite good cognitive status, so no significant cognitive impairment, but at the same time we have a higher CAIDA score indicating a higher dementia risk. And you can also see on the cardiovascular and metabolic factors that we managed to recruit a cohort which seems to be on a risk towards dementia. Like most of the people were not that physically active. A lot of them had cardiovascular diseases like hypertension, hypercholesterolemia, and diabetes. Most of the parameters were quite equal in the intervention and the control group, apart from sex, which was higher in the control group. So females were higher representative in the control group. Next slide, please. These are our preliminary feasibility data. So we are happy to say that we have a quite high retention to date. So the dropout rate is really low with 2.6%. And also the app usage in the first 6 months is relatively high. So the daily app use was 50% in the intervention group and also about 30% in the control group. Our quality feedback was also very nice with the study overall. Next slide, please. Here you can see the system usability scale. This comprises questions about how easy it is to get to learn the Lethe app and how easy is it to use. And most of the questions strongly agreed with the feeling that the Lethe app was quite easy to use and was not so confusing for the participants. Next slide, please. This is just some sentences from participants. Like one participant from our study site, for example, said to me, for me, the study is like an anchor. And also other participants said it was a lifesaver. I've never been this athletic and so on. So we really received very nice feedbacks from the participants. Next slide. So to discuss, we think that digital tools could be helpful in lifestyle intervention programs. They are resource efficient and highly scalable, even to larger populations. However, they have to be tested in this target population. Our study conclusion is that technical studies come with special challenges. We had a lot of challenges, especially in the beginning of the project, but we could manage it. And overall, we have a very positive feedback on the study. But we think that the in-person sessions are necessary to help participants to find into the digital things like the Lethe app and so on. Our final results are expected by summer 25. And I think that's the end of my presentation, and I thank you for your attention.
Elizabeth, thank you so much for your presentation. And again, we'll be coming back to you with a couple of questions in the panel discussion. So thank you very much. So last but definitely not least, I would like to hand over to my colleague, Ilenia Muraseco, who will be presenting the Lethe sub-study. So we'll be looking at both the Temi robot and the Fauna audio glasses. So Ilenia, please take it away.
Yes, thank you, John. And it's a pleasure for me to participate to this webinar. In this presentation, I will talk about the Lethe sub-studies, the Temi robot, and the Fauna audio glasses. Next slide, please. Okay. Before to talk about the Lethe sub-studies, I'll present to you an overview about the status of the Lethe study in Italy at the moment. We enrolled 40 participants now, and three participants dropped out from the trial. One participant belonged to the active group, the intervention group, and two people belonged to the control group, non-active group. Participants in both groups are very motivated and engaging to continue the study and to participate. The study now are continue as planned. Now we will work about the preparation of 24-month visit. Then we are conducting a qualitative interview sub-study regarding digital methods and technical aspects of the study. And this qualitative sub-study is in collaboration with Karolinska Institute. And we are conducting the two sub-studies that I'm going to present to you, the robot and the smart glasses sub-studies. Okay, next, no, please. Now, in this slide, a brief introduction to the aim of the Lethe sub-studies. Well, during the second half of the study, 10 participants from the intervention group in each clinical site were invited to participate in the Lethe sub-studies. One sub-study using a voice interaction app via audio glasses, and the other one using interactive robot, Temi robot. The duration of the sub-study is 8 weeks per participant and per device. The aim of the study, the sub-study, is to explore the acceptability and feasibility of this new interactive technology in supporting the motivation and engagement of the participant in the lifestyle program, including on the Lethe app. Important that the two devices are a complementary and alternative way to use the Lethe app and to participate in the Lethe lifestyle program. Next, please. About data collection of the sub-studies, the feasibility and experiences of the participants are evaluated both quantitatively and qualitatively. Quantitative data are collected regarding the frequency of use, and qualitative data are collected to time. At the first time, at the beginning, and then at the end of the period of usage of the device. Before, to assess expectation and motivation at the beginning, and then to assess experiences toward the device. Then, at the end of the period of usage of the device, the usability of the smart glasses and robot Temi were evaluated by the SUS scale, the system usability scale. Okay, next, please. Before the implementation of the Lethe sub-studies, we perform a program of testing session to verify the operation of the new sub-studies, the smart glasses and the robot. And two members of the Lethe advisory board were involved. And both the member of the advisory board had previously participated in other Lethe activities to provide other feedback. So two sessions of testing, one in Finland and one in Italy, occurred. In Finland, in the clinical center, and with the technical support of the staff for a couple of hours, and in Italy, where was implemented the robot and the smart glasses in real life. In Miriam, Miriam is the Italian advisory board, in the Miriam house, so in real life. And she tested the robot and the smart glasses for a week. the feedback provided from the advisory board were considered to improve and to implement some aspects before delivering the smart glasses and the robot to the participants. Okay, next, please. Now I'm gonna present to you the smart glasses and its function. They are normal glasses that use speakers built in the temple of the frame to direct the sound toward the hair. With use the connection of the bone conduction tech. They are also designed for physical exercise because hair canals are free and users can listen what's going around them while doing, for example, physical exercise. They also are equipped with a microphone for voice command and voice interaction. Participant with smart glasses can use the smart glasses also in activities that are not related to the Lethe program. For example, listen music or audiobooks, or also for making phone calls. It was developed also a Lethe Glass app to use the functionalities of the Lethe app through the glasses. In particular, the ones that can be that are related to the Lethe programs. And here there are the functionalities that users can do access with the smart glasses and with the Lethe Glass app that refers to the following lifestyle domains that are mood, calendar, diet, physical activity, sleep and stress management, personal goal and tiny habits, and diary. Next, please. At the moment, in a University of Perugia in Italy, we have delivered 3 smart glasses. We have just delivered 3 smart glasses. People were agreed to participate in the sub-studies with an informed consent ad hoc. Baseline interview was conducted to evaluate the motivation and the expectation of participants to participate to the sub-study. And in 8 weeks, we will get a glass again. We will evaluate the experience of participants with the smart glasses with the ending interview, and we will administrate the system usability scale. Next. Okay. Now I'm talking about the other device of the sub-study, the Temi robot, or the social companion robot. That is a certified home assistant robot that can navigate around the home by creating a map of its surroundings. For the specific purpose of the Lethe trial, it plays content of the Lethe app via a touch screen, as you can see in this slide, in this figure. And the content of the Lethe app shown by the robots include videos, also video of remote physical activity, physical exercise, C-train cognitive games, educational material, and notification messages from the calendar, for example. Okay, next. Also, the robot can provide additional information, additional assistance to the participant through a remind to plan cognitive training or exercise session. For example, by driving to the participant when it's, for example, time to complete an activity. Temi, a robot, can move into the home of the participant because it has a navigation unit that creates a map of the environment across some sensor placed at the base of the robot. And at the top of the robot, there is as you can see in this figure, this is the screen of the robot that runs with the based on the Android operating systems that runs the Lethe app. Next. At the moment, in Italy, we have already delivered the 5 robots and also taken back all the devices. Baseline and ending interviews were conducted, respectively, both to evaluate the expectation in baseline interview and both to evaluate the experience regarding Temi robot in the ending of the period of the 8 weeks. Also, the system usability scale was administered to all participants at the end of the study to evaluate the usability of Temi robot. And the feedback of the participants is very important to improve the devices for the future users. Okay. Next. Okay. Thank you, and that's all. Thank you for your attention.
Thank you very much, Ilenia, for your presentation. So now I will just bring back I'll ask our speakers to turn on their videos, and I will spotlight them so that we can see everybody. Just for a couple of questions before we close the webinar itself. I think for the panel discussion, we'll start with Ilenia, just because we've just finished the presentation, so it's fresh in everybody's minds. And I just wondered whether the other centres have the same type of sub-studies, and what's the current status of the other centres? So how are things going elsewhere in the project?
Yes. All the clinical centers, all the centers have the same sub-studies. And for the state of the other clinical center, they just delivered the robot in the home participants. And probably they will deliver the smart glasses in January. And we had just delivered the 3 smart glasses and all the robot and taken back all the robot in Italy.
And on the subject of the robot, what feedback have you had from the participants of having the robot in their house and using the robot?
The participants was in the beginning very motivated and involving in participate to the sub-studies. And in the first month they were very motivated. However, the function of the app that can be carried out with the robot are the same that carried out with the Lethe app across the phone. So the feedback that they gave us was that the function that are many of the robot could be exploited to make experience more engaging and diversified from the app in general.
Great, thank you very much, Ilenia. And I actually had the chance to interact with the robot at a recent meeting, which was a very interesting experience. Now just moving over to, Francesca, I see you have your hand up.
Yeah, I think I wanted to comment on this last point. It is very true. The robot is called a social companion. I think there are a lot of potential. One of the aspects that we needed to consider in the Lethe feasibility trial is that we have 4 countries and 4 different cultures. And of course, the moment we speak of social companionship, there is a cultural component that needs to be developed. And in the context of the feasibility, maybe there was no room for that. But in general, the robot has a lot of potential to address in a culturally sensitive manner aspect that the app per se does not do, but it can support the use and the adherence to the app.
Thank
That's
you.
all.
Thank you very much, Francesca. But I'm going to stay with you for a question to you. So my question to you, Francesca, would be why are we focusing in Lethe on lifestyle-based interventions when we already have an approved drug for Alzheimer's, for example?
I think it's true. Thankfully, now also in Europe, the medication that removes amyloid from the brain of people with Alzheimer's disease has been approved, and that's a huge encouraging news. At the same time, we have to think that not everybody is eligible for the drug, that the drug has some side effects that are important and are especially more at risk and frequent in people with some genetic feature that are more recurrent in people with Alzheimer's dementia. So I think it is important to have an alternative to offer to those that are not eligible for the drug. And I think the clear evidence from the multi-domain, from the risk linked to late life dementia indicates that it is important. And actually, we saw in some other research that in people that have amyloid in the brain, the presence of non-well-controlled risk factor contribute to the progression of the brain amyloid accumulation. So there are many good reasons to think of the multi-domain approach that is not mutually exclusive compared to the drug.
Thanks, Francesca. And then looking forward, if we look forward in the next kind of 10 to 15 years, what do you see that the future brings us with regards to Alzheimer's?
I think what we need to think is that there is no silver bullet, there is no one solution. And in the same way, HIV or cancer are treated with multiple approaches that include pharmacological and non-pharmacological, most likely this is what's going to happen. Now, the new medication recently approved, the multi-domain trial, are opening a new era. And the good thing is that although we are behind compared to other disease fields, we're going fast because we're building on previous experience. And I think I can also take the chance to address one question that has been put in the chat by Christopher. What if there are any challenges in implementing the multi-domain intervention across different populations? Of course, there are. One of the main I presented in the initial slide, there is a huge misconception about seeing dementia as a normal part of aging, and that makes it difficult to even think of approaching the concept of risk reduction or prevention. When it comes to the multi-domain approach, challenges are different in different settings because it's the cultural, it's the economical feasibility, is the societal organization. But at the same time, it is a way forward, especially if we think the sustainability aspect of it. And so it's about to work one-to-one with the different setting to find a doc solution. I hope I answered the question, please.
Yes, you did. Thank you very much. That's great. And I think we actually have a question from the audience from Pushdak Marne. I don't know whether you just want to briefly put on your microphone, or if not, then you please feel free to add the question to the chat, and I'll make sure that the speakers receive your question. So So I think, Bushrak, if you wanted to add your questions to the chat, we'll do it that way. And I see that Elizabeth, I was just coming to you with some questions, but you have a comment on one of the previous questions, I feel.
Yes, I just wanted to highlight what Francesca just said, because I think that's an important issue these days. That so it's a great achievement that we have now monoclonal antibodies against amyloid beta, but still we have to keep in mind that dementia is not one disease. It's a complex syndrome and has different phenotypes, so to say. And so the Alzheimer's disease and the rather poor Alzheimer's disease might be addressed with these new therapies, but a lot of other dementias and also the mixed dementias and the vascular dementias, they are not addressed by such therapies. And I think it's most important that we don't split this up, that we need to see dementia as a holistic thing. And I think there was a nice recommendation from a European group led by Frisoni, that he said we need some like brain health dementia centers where people drop in and get information about cognitive status, and then some of them might get the new therapies, but many of them might need something else, and that might be as well as like lifestyle recommendations and even lifestyle interventions, as we know it now from Finger and Lethe trials. And I think we need to keep that together, these developments.
And Elizabeth, I'm not sure whether you would like to add anything additional to the kind of the biggest challenges that you faced during the intervention trials. What were the biggest kind of obstacles you had to overcome? Because I imagine with a study this big, there were quite a few.
Actually, yes, it was quite difficult in the beginning, I think. And I would say one of the most difficult things is that clinicians and technical partners have to get used to each other. So they use really different languages and they come from really different sides of the universe. And especially in the beginning, we had the problem of COVID. We just met online for a kickoff meeting. And I think the live meetings are much better for getting to know each other and be easy with each other. And I think, we needed to establish a language where we could communicate well. And I think in the beginning, the whole technical development. So we needed to establish this Lethe app together with the technical partners, and then had to implement it in our clinical work. And that was actually a lot of man and woman power needed to talk about this, to discuss this very solely, and after eventually implemented in our clinical trial. And I think the beginning was the most challenging part. And in terms of the participants, I think retention rate, adherence rate is also a hard thing. I think this hybrid concept where you can deliver these digital solutions, but at the same time you talk to the participants and you keep in mind the individual interests and individual benefits and risks of each individual, that makes such studies, digital studies, feasible. So I couldn't think of a good working only digital study. I think that would be hard for participants.
And Elizabeth, just kind of on that note, we speak a lot about kind of the study team's perspective on what we've been doing. What would be one of the highlights from the kind of the patient perspective during the study? Is there anything you can share with us on that?
The highlight? No, I think so. The highlight is, I think the participants who are very motivated, they are very happy, as I already mentioned. So I think the engagement with the physiotherapists, so have some participants, they say they never could do, I don't know, a kind of exercise their whole life. And now they can manage to do this exercise in the age of 67, for example. And I think that's very motivating. Also diet. Some of our participants really managed to reduce weight, for example, managed to address specific vascular risk factors during our risk intervention sessions, cardiovascular risk interventions. And they also like the group meetings. So the WhatsApp meetings, and they also gather together for coffee or even for lunch. Not all of them, of course, but some of them. And that's also a very nice part in the study.
That's great to hear, and I think it must be very rewarding when you hear this kind of positive feedback from the patients, because
Yes.
you know, from their perspective as well, it's an investment from their time and effort as well. So that's always great to hear that it's very well received. Just quickly, we have another. I mean, I'm aware we've got 3 minutes left in the time, but I think we've got time just for one quick question, and that's from in the comments section from Pushrak. Apologies if I've mispronounced your name there. And they have asked, how can a startup like ours collaborate with Lethe to implement low-cost preventative care solutions? And Patricia is co-founder of Manastic, a tele-neuro rehab application for low-cost multi-disciplinary rehabilitation of dementia patients in low and middle-income countries.
Yes.
So I don't know whether anyone would venture to.
Yeah, I could take this because I talked to Stan yesterday, Stan Hanke, and he told me about this. So I think the best way would be that he talks to Stan Hanke, who is the coordinator of the project, and then we can find maybe another round where we could discuss and collaboration with him and with his group. And I think Stan and he already spoke to each other, and maybe, we could encourage such meetings again.
So thank you very much for that question, and we encourage you to reach out to the project coordinator or any one of us, and we'll definitely put you in contact with Sten. But as from what I can hear from Elizabeth, you're already in contact there, Pushtak. But thank you for your interest, and it's always good to hear that people are interested in the project results and how to continue them. We are now running out of time, so I would just like to say, firstly, thank you very much to all of the speakers for your very interesting insights into the project and what's being done and what's still to be done this year. So the project will be continuing up until the end of June 2025. So please keep a lookout on our website, not only for the recording of this webinar, but for all of the news and updates from the project and study team. And as we come into this last final phase, we'll start to publish the results of the project. So it will be an extremely interesting time. And I'd like to say thank you to everyone who joined us today, and for your engagement through the chat. And we look forward to seeing you when we come back in January. Our next webinar is programmed for the 17th of January. It will be a collaboration webinar with other projects that are also dealing with dementia in various different ways. But more information about that on the project website over the next coming weeks. So without further ado, thank you very much. And we look forward to seeing you next time. Take care and
Thank
happy
you.
holidays.
Thank you.
Happy
Bye.
holidays. Bye.